Welcome, everyone. My name is Kate Blackburn. I'm a Senior Program and Policy Analyst with Nemours Children's Health System. We're thrilled to have all of you with us today. There's a lot of interest in today's topic, as evidenced by the fact that around 400 people have registered, and we have a packed hour, so I'm going to jump right in with a bit of background information and then turn it over to my colleague Derek Carr from ChangeLab Solutions. Nemours is an internationally recognized children's health system that owns and operates two full-service children's hospitals, Alfred I. DuPont Hospital for Children in Wilmington, Delaware, and Nemours Children's Hospital in Orlando, Florida. We also operate pediatric specialty clinics in Delaware, Pennsylvania, New Jersey, Florida, and Georgia. And though our physical presence is in the Delaware region and Florida, Nemours also works at a national level to help children grow up healthy. Through our National Office of Policy and Prevention, which is where I sit, Nemours collaborates with external partners to spread and scale effective innovations in policy and practice and prevention nationally. Within the office is Moving Healthcare Upstream. Moving Healthcare Upstream, or MHCU, is a collaborative effort co-led by Nemours and UCLA's Center for Healthier Children, Families, and Communities. The work of MHCU is based on the notion that health systems can address persistent and costly health inequities by moving upstream, beyond the walls of hospitals and doctors' offices and into the communities, collaborating with community-based organizations to address the root causes of disease. The various areas of work within MHCU share a common focus on supporting hospitals and other stakeholders in testing and spreading strategies to move upstream, and in doing so to inform the field and accelerate the upstream movement in the field as a whole. So this webinar series is just one example of MHCU's work to spread knowledge in the field. We invited ChangeLab Solutions to co-present the webinars with us, given their expertise in providing training and technical assistance on the creation of policy strategies. In a moment, I'll turn things over to Derek to say more about the work of ChangeLab, but just a few important notes first. So again, I'd like to acknowledge and thank ChangeLab Solutions for being our co-host and our partner for today's webinar. If you guys aren't already, we encourage you to follow MHCU and ChangeLab Solutions on Twitter for more on this topic, so this webinar and the work more broadly. We'll be live tweeting during the webinar with the hashtag UpstreamLabs, so you can join in that conversation or you can follow that conversation using the hashtag, and the slide that is visible now shows both of our Twitter handles if you want to follow us. I'd also like to acknowledge and thank the Kresge Foundation and Nemours Children's Health System for providing funding for today's webinar, so a huge thanks to both organizations. And if you're interested in an opportunity to roll up your sleeves and get to work on creating or strengthening your policy work after this webinar is over, you might be interested in joining a short-term policy learning lab that we'll be launching next month. The Policy Learning Lab is going to provide customized coaching, technical assistance, and resources from ChangeLab Solutions, MHCU, and a national network of academic and on-the-ground experts. Members of the Learning Lab are going to participate in virtual group meetings once a month from August to October, and will receive individual consultant coaching between meetings. You can visit MHCU's website for details and to apply. The link for the applications and information is on the slide, and we'll also include it in our post-webinar email to all of you. And a link was also included at the bottom of your meeting confirmation email for today's webinar in the part that says information around the Policy Learning Labs. We're taking applications through Friday, July 28th, and we'll announce members during the week of August 7th. So it's a great opportunity. If you have any questions related to the Policy Learning Lab or the application, you can email the MHCU team at the email here on this slide, or you can call me at this number that's listed. So having laid the background, let's get started. Thanks to the Green and Healthy Homes Initiative and to Trinity Health for joining us today as presenters, and thanks once more to our co-host from ChangeLab Solutions. At this point, I'm pleased to introduce Derek Carr, Staff Attorney at ChangeLab Solutions. Welcome, Derek.
Thank you, Kate. As Kate mentioned, my name is Derek Carr, and I am a Staff Attorney at ChangeLab Solutions, where I work primarily in tobacco control and chronic disease prevention. And just to start out, I have to give you the spiel why I am a lawyer. I am not your lawyer. And at ChangeLab Solutions, we don't provide legal advice or enter into attorney-client relationships. So everything that we're going to cover here today is purely for informational purposes. For those of you who haven't worked with us before, ChangeLab Solutions creates innovative laws and policies to ensure everyday health for everybody. Our solutions address all aspects of a just and thriving community, like housing, childcare, transportation, public safety, the environment, and what we're going to dig into a little bit here today of tobacco control. And I also want to highlight some resources available on ChangeLab Solutions website, particularly our Law and Policy 101 materials, a link to which will be provided in the chat box as well as in the emails following this webinar. So we have a couple main items on the agenda for my presentation today. First, we're going to kind of go back to the basics and talk about how programs and policies differ, as well as the benefits of policy. Then we're going to dive into a real-world policy example, Tobacco 21, and how it connects with asthma, as well as introduce the story of Tobacco 21 in Michigan. And before we get into the substantive materials, I want to cover a couple housekeeping matters. First, in the bottom left corner of your screen, you'll see a chat box where you can type and submit questions. You should feel free to submit questions as they come up, and we'll keep track of them as we go along, but we're going to hold off on answering them until the Q&A session after all of the presentations are done. And if we don't get a chance to answer your question on the webinar today, you should absolutely feel free to contact us directly afterwards, and our emails will be on the last slide. Second, you'll be prompted to take a short survey following the webinar, and we kindly ask that you complete the survey because your feedback helps us improve these webinars moving forward and make them even more helpful for you all. So with those housekeeping matters out of the way, let's jump into the substantive material. So what is policy, and how do policies differ from programs? First, while programs are systems implemented by organizations, policies are written statements about how things get done. Second, while programs provide services to particular populations, policies actually affect how organizations operate or how citizens live at a much more fundamental level. And third, while programs are usually voluntary in nature, policies are binding. They require or prohibit certain courses of conduct, and there are often consequences for failing to follow the policy. And programs and policies exist on a spectrum. They're not kind of a one or the other type thing. I like to think of the difference in terms of the scope of who the change most affects. Programmatic changes happen on the individual level, whereas policy changes affect groups of people, so an entire organization or even an entire community. And this particular spectrum shows the range of interventions for an organization who wants to make their facility smoke-free or even tobacco-free. Many communities, or even most, already have some smoke-free policies, but there are still a lot of places doing programmatic work. So you'll see on the left side of the spectrum, you have programmatic interventions like educating staff and clients about tobacco use and secondhand smoke. But as you move along the spectrum to the right, you can see how the steps progress to include things like supporting cessation efforts and discussing tobacco control and cessation policies. Eventually, your organization or community can adopt a 100% smoke-free policy. And the process, importantly, doesn't stop once you've adopted a policy. It's important to continually enforce and evaluate the policies to make sure they're having their intended effect and not resulting in any unintended consequences. When most people think about policy, they think about laws and regulations. They picture the government dictating how something will happen or the government prohibiting certain activities or conduct. But policy really is about much more than just legislation and regulations. Everything from local ordinances to contracts can be considered policies. And perhaps the most relevant or well-known to many of you on this webinar, you'll see hospital policies in the bottom right corner. So just to put this to a little bit of context, you can think about, say, policy supporting exclusive breastfeeding in hospitals, such as not providing infants food or drink other than breast milk unless medically indicated. And that's just one example of an upstream hospital policy that can affect downstream health issues like asthma. And there are three main commonalities that make something a policy, and that's the same whether it's a public policy like a city law or a private policy like an organizational smoke-free policy. And those three commonalities are, one, it includes a written statement that reflects the values and decisions of a public body or private organization. Two, the policy is binding and enforceable. There's some measure of accountability for following the policy. And three, the policy is broadly applicable to a geographic area, a type of institution, type of physical space, or a particular group of people. So why do we focus on policy? Policy is a tool used to document decisions and change physical environments, community norms, and the way organizations and systems operate. Policy has the potential to affect people's decisions and behaviors across a large population. And although policy is just one tool used to improve health outcomes, it's the most important tool because it sustains change and it often achieves really broad results, and it does so more efficiently and at a lower cost than individual or group education and clinical approaches or likewise approach. So one example of policy and upstream policy of that is Tobacco 21. In most areas of the country, probably where many of you live, retailers can sell tobacco products to anyone 18 years of age or older, but that's rapidly changing. The research shows us that the vast majority of current adult smokers, 95% of them, begin smoking before age 21. And that period between the ages of 18 and 21 is when many casual or social smokers transition into regular daily use, making this a critical intervention point. Tobacco 21 seeks to align the minimum legal sales age for tobacco with this research by raising the age from 18 to 21. And importantly, these policies generally focus on the sale of tobacco rather than the use or possession of it, so it's the retailers who face penalties, not the youth. And highly respected scientific and medical authorities like the Institute of Medicine have concluded very strongly that Tobacco 21 is a policy that will save lives. So this is an approach that's a win-win for public health, for equity, and social justice. It's a win all around. And the most recent statistics show that there are 3 states and more than 250 communities that have adopted this policy. And Tobacco 21 demonstrates how a rather simple and straightforward upstream policy can result in tremendous downstream public health benefits. You can see on this slide how Tobacco 21 will lead to big declines in smoking initiation, smoking prevalence, and smoking-related deaths. And as most of you are aware, tobacco use and exposure to secondhand smoke is a big risk factor for pulmonary problems such as asthma exacerbation. And evidence does suggest a link as well between tobacco and developing asthma. And the key takeaway here is that by implementing upstream policy levers to address those root causes, you can make really tremendous progress towards reducing downstream effects on the health conditions you're really trying to address. And I want to shift gears a bit now to introduce you to one specific journey towards enacting an upstream policy, and that's the story of Tobacco 21 in Michigan. But before we get to that story, we need to talk about the legal doctrine of preemption. And I warned you earlier that I'm a lawyer, so I couldn't get through this entire webinar without throwing some legal jargon at you. So here it is. Preemption refers to when a higher level of government, like the federal government or a state government, takes away the authority of a lower level government, like a city or county government, to regulate certain conduct or behavior. In Michigan's case, there were numerous state laws that people pointed to as preempting or taking away the authority of local communities' ability to enact Tobacco 21 policies. They said it couldn't be done on the local level, that it was an quote-unquote impossible task. But, and there's always a but, right? But Trinity Health and other stakeholders weren't deterred, and they partnered with ChangeLab Solutions to see whether it was possible to thread the needle on Tobacco 21 policies in Michigan. Under the partnership, my colleagues and I conducted a comprehensive review of the various Michigan state tobacco laws and court decisions and provided a legal analysis on how these laws and court decisions could apply to a local Tobacco 21 law. Based on that research, legal research and analysis that we conducted, we then developed model legislation that would enact Tobacco 21 at the local level while minimizing the potential for the laws to be successfully challenged on preemption grounds. And with that kind of background context in mind, I now want to turn things over to our next speaker, Cindy Brewitt, Program Consultant for Community Health and Wellbeing at Trinity Health, who is going to talk about this partnership and their work on Tobacco 21 in much greater detail.
Thank you, Derek. Before I dive into our policy story, I'd like to talk a little bit about defining who we are. So Trinity Health is one of the largest multi-institutional Catholic healthcare systems in the United States. In fact, we serve people and communities in 22 states from coast to coast, and we have 93 hospitals and 120 continuing care locations. And this includes home care, hospice, PACE, and senior living facilities. In fact, we're the nation's single largest PACE provider. And we deliver almost 2% of all babies born in the U.S., and we employ more than 97,000 full-time colleagues, and this includes 5,300 employed physicians. And at Trinity Health, we are extremely proud of our top-notch physicians and other clinicians, but nonetheless, we know that we can't achieve better health in our communities by working alone, because the root causes of poor health do not start necessarily in hospitals and clinics. Rather, good health starts in homes, schools, neighborhoods, workplaces. Even the very best care provided by our top-notch clinical staff cannot change the fact that good health is largely driven by social and environmental factors that exist within all these communities that we serve. So the importance of healthy homes and clean air are good examples of how the environment around us impact asthma. A number of other policies and environmental issues and social determinants that are not the root causes of poor health are illustrated on your screen in this slide. So it's astonishing that access to care and quality of care, they account for only 20% of the factors contributing to health outcomes. That's just the tip of the iceberg. This truth has been a core principle underlying the passage of the ACA and most health system transformation efforts. However, yet according to a national case study published by the Prevention Institute, and I quote, relatively few are implementing healthcare delivery and payment reforms that include community prevention strategies as a key pillar for improving health in the United States. And so I'd like to just pause for a minute and give kudos to my organization, because I'd like to think that Trinity Health is a leader in this regard. So when you look at this slide, at Trinity Health, we're expanding our historic definition of community benefit functions into a much broader concept of community health and well-being. So as you can see on the right hand, this expanded concept of community benefit work is a key pillar of our strategic framework for becoming a people-centered health system. We know that transforming the health of our communities will require fundamental changes in the way that we think about health at the community level, and how through all of these collaborative efforts, we can work together to achieve positive health outcomes. So when we think about improving the health of the entire community, I'm not just talking about patients who walk into one of our facilities, because from community health and well-being, we don't look necessarily at what happens in the doctor's office. We look at what happens in the community from our lens. And this framework can help address those social determinants of health that you saw in the previous slide, and also at the same time help empower our low-income, disadvantaged, and underserved persons when they're included in these upstream efforts to transform their community into a healthier place. So these upstream efforts that I'm talking about actually include a priority focus on both tobacco control and obesity prevention, both of which are key issues for anyone who's concerned with asthma. So in fact, when you look at this slide, as part of our strategic planning process, we have very bold and aspirational metrics. And these are aimed at reducing tobacco use and childhood obesity in the footprint of the communities that we serve. And this Tobacco 21 effort falls into this work. So we're investing in tobacco control and obesity prevention because every one of our hospitals' community health needs assessments, or CHNAs, they have identified significant health needs that are largely driven by either tobacco use or obesity. And of course, I don't have to tell this group that investing in tobacco control efforts, including 21, makes sense, but I'm going to reiterate some of the points that Derek said just because of its significance. So tobacco does remain the leading cause of disease and premature deaths in the United States, and it's one of the largest driver of health care costs. Chronic diseases are the most common and costly of all health problems, but they can also be the most preventable. And as he mentioned earlier, adults over the age of 21 rarely start smoking. Almost all current smokers picked up their habit when they were kids. Specifically, 9 out of 10 adult smokers tried cigarettes before 18, and their progression typically occurs in young adulthood. So the Surgeon General concluded that cigarette smoking is casually associated with asthma exacerbation and a whole host of other health problems. And investing in this policy work is relatively new for us, but it really all began back in December of 2015. That is when Trinity Health endorsed Tobacco 21 as a uniform statewide policy priority. So as a result, this life-saving measure was incorporated into our community health and well-being performance metrics that every single one of our hospitals across our 22-state system is accountable for. So the tie to our strategic planning documents and measuring this effort as part of a performance metric actually helped us access and leverage a lot of our internal assets. For example, our communications and our advocacy support. So back in December 2015, only 94 localities in the United States had these Tobacco 21 laws. So if you fast forward into 2016, we provided at that time a small financial grant to the Campaign for Tobacco-Free Kids to help bolster their Tobacco 21 efforts. So the slide that you see on your screen right now show excerpts from an article that describes these first-of-its-kind investments, if you will, in Tobacco 21. And we partnered very closely with Dr. Rob Crane from the Preventing Tobacco Addiction Foundation, and he is the person who started this movement years ago. And speaking of Dr. Crane, this image that you see right now comes from the Prevention Tobacco Addiction Foundation's website. He does update this regularly, but I have to warn you, within days, maybe even before this webinar is archived and sent out to you, this image might be outdated. And I say that because so much progress is happening so quickly. In fact, to recap, in the last 18 months, other nonprofit health organizations have incorporated Tobacco 21 into their performance metrics as well. And Trinity Health partnered with the National Association of County and City Health Officials and went to Capitol Hill back in April of 2016 and hosted the nation's very first congressional briefing on Tobacco 21. And numerous public education efforts around Tobacco 21 were launched. We collaborated with our partners to share our experiences at national conferences all across the country. And we are spreading the word in webinars and seminars and webinars just like this one. We provided toolkits and technical assistance to policymakers, community advocacy groups, and other health systems. And just a note, we would be happy to share any sample PowerPoint slides, social media campaigns, letters to the editor, and any other tools that we have in our toolkit to anyone on this webinar. So basically, as a result of all these efforts over the last couple of years, the number of localities to adopt Tobacco 21 has more than doubled. And many, many other groundbreaking victories are really on our horizon. The results are undeniable, and it's clear that Tobacco 21 is an issue whose time has come. So in those short 18 months since Trinity Health endorsed tobacco control policy as a strategic priority, and that being said, Tobacco 21 is our hallmark tobacco control effort, more than 1/3 of the states that we serve have experienced significant tobacco policy wins. This is a partial list of places where our hospitals with other national partners, such as Campaign for Tobacco-Free Kids, the Prevention Tobacco Addiction Foundation, have recently worked together to really make a powerful and very, very rapid difference. And Trinity Health, at Trinity Health, we actually believe that we have a responsibility to advance local and institutional policies to improve health. But our responsibility in this space is really what we're considering a shared responsibility. And likewise, while we've invested in Tobacco 21, the credit for this work is not ours alone. So we must share credit because the way that this work gets done so quickly is truly through broad multi-sector partnerships, and that includes hospital community partnerships. And on this slide, you can see just a partial list of some of the partners. Before I wrap up, I want to say a few more words about Trinity Health's partnership with ChangeLab Solutions, and more specifically the work that ChangeLab Solutions did in Michigan. There are a number of laws in Michigan that Derek pointed to that Tobacco 21 opponents say strip away our local control. And as a result, Tobacco 21 laws at a local level in Michigan was previously really considered impossible. So we made some modest investments in ChangeLab Solutions, who conducted legal research for us. And in addition to that research, they also developed model policies at both the city and the county levels. And their expertise helped us navigate a very thorny legal landscape in Michigan. And as a result, the Tobacco 21 law was passed in Ann Arbor, Michigan, and as well as in Genesee County, which some of you might know is the home of Flint, Michigan. This slide here is a national survey that summarizes states that might face similar legal barriers to what I just described. And so you can see in Michigan, it's still a light shade of red, and that's because legal questions still remain in Michigan, and a judge will decide the ultimate fate of Genesee County's Tobacco 21 law this fall. But regardless of the outcome, we know that we're in the strongest position possible because of research and technical assistance that was provided by Trinity Health's partnership with ChangeLab Solutions. And there are a number of things that we suggest that should be included in a strong Tobacco 21 law. And our partners at ChangeLab Solutions have helped us through this many, many, many times. And their partnership has turned out to be an incredibly wise investment. And also our friends at the Preventing Tobacco Addiction Foundation have a website that we consider an invaluable resource as well. And of course, our partners at the Campaign for Tobacco-Free Kids have many, many more resources available. So if you are moved by this topic, Trinity Health is happy to share our basic Tobacco 21 toolkit with any health system or any community partner who is considering this work in their community. I believe there are questions that are being held until the end of this webinar, and hopefully we can address any of those at our time and offer our toolkit. With that, I'll conclude so that I believe we have Ruth Ann Norton, President and CEO of the Green and Healthy Homes Initiative.
Ruth, do you want to take over?
Oh, and thank you very much, and what a terrific set of presentations. I'm going to take us to a little bit of a turn looking at housing conditions, and at the Green and Healthy Homes Initiative, we are aligning, braiding, and coordinating resources to create healthier, safer, and more energy-efficient homes to improve health, economic, and social outcomes. We began 30 years ago in the city of Baltimore as Parents Against Lead and have been battling the issues of environmental health and social determinants in housing. So every day we are waking up and trying to solve for the problem of the over 9 million families that live in housing that are beset with lead hazards, asthma, injury issues. If you add into that the number of homes that also are undermined by energy efficiency, that number goes to 30 million U.S. families every year who are suffering results of increased incidence of asthma, in emergency department visits and hospitalizations for children and adults, increased rates of lead poisoning, increased rates of fall and injury issues. And in fact, this issue that we focus a lot on in asthma is the number one reason that children are missing school, and it also then leads to one of the leading causes of parents with young children who are missing work. Coupled with 535,000 children a year with lead poisoning, this becomes a very heavy cost burden along with the injury issues on Medicaid and Medicare in the United States. So we're really trying to solve these issues that, when we address with evidence-based practices, have huge results in reducing that over $100 billion a year burden. So we have taken an approach at the Great and Healthy Homes Initiative, now operating in over 30 U.S. cities and working on national policies around the Center for Medicaid Services, HUD, the EPA, and the Department of Energy, to align the resources from philanthropy, the federal, state, and local governments, and the private sector to more efficiently put in practices that are targeted to reduce medical costs, typically those of Medicaid children and adults and Medicare, improve the efficiency of government by having a single portal of intake by which families can address these issues and have a better net result on the back end of not only health, which I will talk about in a large part here, but on stability of housing. In fact, in the turnover rates of housing, communities that have 36 to 42% a year turnover rate, we've been able to reduce those to 6%. And you'll see here the dramatic results that we've had on health by using these practices that are promoted by the Community Guide at HHS and NIH that call for not only education around asthma in the home, 40% of which asthma cases going to the ED and to the hospital are caused by unhealthy housing conditions, according to the Robert Wood Johnson Commission on Building a Healthier America. But we're able to make big changes in those cost factors and in the social determinants of health long term. If you look at the 3 studies that we have done on the use of evidence-based intervention and how they have impacted as the rates, the hospital utilization, and outcomes in the community, you have 3 good examples here. In Baltimore, where we did a study with the U.S. Department of Housing and Urban Development, Hopkins, and the University of Maryland, Baltimore County, we looked at 240 families by which we were delivering health-based housing interventions, including health and safety, asthma reduction, lead, and energy efficiency work. But if you targeting in on the issue of asthma, we had a 66% reduction in asthma-related hospitalization. In the state of Maryland, that cost is going to be around $7,500 to $11,000 per hospitalization. Also, in the 139 children in that cohort of 240 families, the 139 children who had chronic asthma, we were able to improve their school attendance by 62% while reducing those hospitalizations and emergency department visits, and improve work attendance by parents by 88%. So clearly having an impact on health, on cost savings, and on the long-term trajectory of families. In Philadelphia, in a program between the Philadelphia Public Health Department and St. Clair's Hospital, they did even better. They had 70% fewer asthma-related hospitalizations and 76% fewer asthma-related ED visits. And in Cleveland, their results were astoundingly good as well, with a 58% reduction in asthma-related hospitalizations and a 63% reduction in ED visits. All of this work is based on long-term investments, finding what works from the U.S. Department of Housing and Urban Development, from the Center for Disease Control and Prevention, and from local programs like the Community Development Block Grant and others. These asthma programs that we're looking at NIH, CDC, and EPA have reviewed the asthma care and recommended the 4 components: medication and medication adherence, assessment and monitoring, patient education, most of which is paid for and reimbursed through public health programs, Medicaid, and health insurance. The 4th one, the control of environmental factors, however, has been the challenge and the one that has highest return on investment, but the least amount of funding publicly to support these environmental interventions. These asthma programs use community-based elements to reinforce clinical interventions while addressing these environmental triggers for the patient and the family. And the research has shown that environmental control should be performed in a comprehensive manner, that we're using this multi-trigger, multi-component approach effectively to do root cause remediation on issues of mold, ventilation, removal of carpet, dust and other debris in the house, and looking at the issue of pest management. And the evidence has clearly shown that we can have long-term and sustained results, improving outcomes. So there's a strong business case for asthma. Not only is there a strong moral and education case on reducing asthma-related absences from school, but we have, with the 25 million Americans who have the current asthma diagnosis, over 2 million ER visits and 500,000 hospitalizations, costing Medicaid and public dollars billions of dollars every year. And as I said earlier, it's estimated that 40% of this cost can be reduced by improving the home environment. And so in the studies that have been done through HUD and other NIH and other entities, that we've been able to establish that for every dollar that we spend on environmental asthma intervention and reduction of triggers, that there's a $5 to $14 return on investment for the public. So we have a question that we are posing, is whether we continue to spend $51 billion a year annually in medical costs, or do we invest in what is proven to work and to be sustained, and that is improving the home environment. And that's the work that we are trying to do. So the Green and Healthy Homes Initiative, we have been leading the development of an innovative funding toolbox to build the sustainable resources for prevention for nonprofits, for local public health and housing departments, and for state government. So we're working through the Medicaid coverage and rule changes to utilize community-based work that has a dramatic reduction on asthma and be able to reimburse for those efforts that are proven to work. We've been fortunate to see and help to assist on waivers that have come about from Michigan, in Maryland, in Oregon, and Ohio that allow for interventions in the home, everything from carpet removal to venting to dehumidifiers and air conditioners to improve the home environment and pest management to improve the home environment. We're also exploring the increased use of the IRS-mandated investment of hospital community benefits, and we've done this in a partnership with Presence Health in Chicago, who is also talking with the 26 nonprofit hospitals in the city of Chicago to have a coordinated investment around environmental health interventions to reduce asthma. We're looking at ways to use administrative claims to drive the value-based payment mechanism, utilize value-added services, and explore Pay for Success, which we're doing through 12 feasibility studies funded by the Robert Wood Johnson Foundation, JPD Foundation, and the federal government. I'll talk about that in just a minute. But in looking at the Medicaid coverage and rule changes, the coverage of asthma care varies by states. And so we do recommend that our partners on the phone and our partners that we work with utilize the American Lung Association's great information that provides information about what may be covered in each state currently. We were really glad to see today Congress continue to fund this work also with a $29 million investment in asthma through the CDC to continue to perpetuate better education and better intervention exploration. The Medicaid rule change includes reimbursement for non-clinical professionals, nonprofits, organizations like the Green and Healthy Homes Initiative, that for education, case management, and community health workers services. Services must be recommended by a licensed clinical provider, a physician or an RN, and CMS must have approved a state plan amendment. But we're looking for that to move further, as I said, into the environmental interventions for root cause remediation. So I want to look at a couple of case studies where there's been advancements to put forward and push forward this evidence-based practice work. In Missouri, they have created Medicaid reimbursements for specialists who do home visiting for low-income patients with severe asthma, for education and assessment of the environmental asthma triggers in the home. Eligible patients identified as frequent users of the ED, prior hospitalizations or frequently prescribed oral steroids for asthma are eligible for the program. And this plan costs the state of Missouri only $524,000 a year, the federal government matching that with $4.7 million in Medicaid dollars. We also are looking at not only expansion of models like that in Missouri, but Medicaid waivers and looking at the 1115 waiver demonstration projects where there is a purpose. The purpose is to develop pilot or demonstration projects that expand eligibility, that provide services not typically covered by Medicaid. So in our look at this, it's the environmental intervention. And to use innovative delivery systems in the community to lower chronic illnesses such as asthma. For states to be eligible, a state must submit to the Center for Medicaid Services an application for an 1115 waiver, and it will be approved for a 5-year period, typically showing that it's budget neutral. Examples of statewide delivery systems or districts that are using the 1115 waiver include California, Kansas, Massachusetts, New Jersey, New York, and Texas. And in the state of New York, GHHI is working with the State Energy Administration actually to look at housing intervention services around health and energy and how it can be repaid through Medicaid and public health systems to lower the rate of asthma and improve housing condition stability. So the other tool that we're looking at is hospital community benefit investments. We think this is a powerful tool that is underutilized greatly in the U.S. to help in communities where hospitals are mandated to do this reinvestment through the IRS, but have a huge opportunity to improve the health around kids and seniors, around the housing stability, and around the ability to improve social determinants. Nonprofit hospitals are required by the IRS to make these community benefit investments that are transparent and concrete and measurable. Through this process, we have partners who are engaging in the community health needs assessment that's conducted every 3 years by every nonprofit hospital in the country to make the case on housing intervention to reduce the incidence of asthma. And those decisions are made by participation in those community panels. Community benefit investments can encompass physical improvements and housing and environmental improvements, and we think, therefore, opening the door to these environmental interventions. And the services that are not included in the community health needs assessment can still be supported by community benefit funds, and we think the evidence in the case to be built with nonprofit hospitals is very strong and is being looked at greatly. One example of this is the St. Joseph's Health System, who's invested in construction of affordable housing, new housing, an 81-unit development for very limited income seniors, a 23-unit development for homeless persons with AIDS. But we're looking, as I said, with Presence Health, and we'll talk about that in a minute, to build a network around the environmental trigger reduction to improve outcomes for asthma. Another mechanism that we're looking at and where we're conducting 12 feasibility studies, 11 of them funded by the federal government and by the Robert Wood Johnson Foundation, is the model of pay for success, to allow private investors to work with Medicaid managed care organizations in upfront investments for community-driven asthma reduction remediation in the home, and to be repaid utilizing the Medicaid managed care rule changes around value-based purchasing and state plan amendments to pay for those remediations where there's proven results in reductions of ED visits and hospitalizations. GHHI has teamed with Nemours, a leading actuarial analysis company in the United States, Health Management Associates, Social Finance, and others, to create this model feasibility studies to show the proven return on investment for cash savings for reducing the utilization of the hospital system. Under the Pay for Success model, repayments of the private sector capital investment are made if and only if approved by state plans and utilized through the Medicaid authorization, but are paid back if and only if the intervention works. So if asthma reductions are made, then that is a trigger for repayment. It does not encompass interventions that would not work. So in this work that we're doing across the country, you can see a map of those that we are looking at. We have ongoing feasibility studies in the top half there. Then we have those that we've completed in Buffalo and Grand Rapids and Memphis, where I'm sitting today with Bonheur Children's Hospital, Springfield in Massachusetts. And we have 2 of these transactions that are in the transaction structuring phase for funding, we hope, by the end of this year in Baltimore and in Salt Lake. And in Baltimore, we have Johns Hopkins as our partner, 3 priority partners, and the University of Utah in Salt Lake. So some of the examples that are increasing for the asthma impact. Bonheur, as I said, where we're working today with Bonheur Children's Hospital through their CHAMP program, which was designated by the EPA as one of the leading effective asthma reduction programs in the country. Habitat for Humanity, providing that evidence-based housing intervention, and the University of Memphis in helping with the evaluation work on this. Also in Philadelphia, St. Chris Hospital for Children, who is partnered with local community partners in the Department of Health to amplify public resources, and in Chicago, Presence Health, where the hospital is investing in preventing uncompensated care through asthma reduction through St. Mary and Elizabeth Hospitals, who are utilizing grant dollars and community benefit dollars to fund programs that will help to reduce this uncompensated care for asthma patients. In the Bonheur program, Bonheur is coordinating resources and services to meet the needs of high-risk pediatric patients that they see in their program. Bonheur will be providing the in-home asthma resident education and care management services, Habitat doing the environmental intervention and remediation, and the University of Memphis not only in larger roles, but will provide legal support through its medical legal partnership that fits within Bonheur. And so we'll be looking at medication adherence through the in-home education program, assessment, environmental intervention, and sustainability. And this is being looked at as a pay-for-success program through the 3 Medicaid managed care providers in the city of Memphis. At the St. Chris program, they are partnering with the local Philadelphia Health Department, where St. Chris Hospital is providing the asthma intervention and education work, and Health Partners, one of the larger Medicaid managed care plans in Philadelphia, is working with GHHI on a feasibility study to provide sustainable financing through the Pay for Success model. And the Philadelphia Health Department will be partnering to manage other community resources that can be aligned, integrated, and coordinated to improve the overall stability and environmental health. This is an already proven program, as we had said earlier, where we've shown a reduction of 70% of the asthma-related hospitalization for chronically asthmatic patients. In the Presence Health model in Chicago, Presence Health is looking to invest community benefit dollars to prevent uncompensated care losses in the future. And they are working to look at the other nonprofit hospitals in the community to invest in these evidence-based practices. The intervention partner in Chicago is Elevate Energy. Not what you would typically look at in an asthma reduction program, but Elevate Energy in their energy efficiency work has performed flood hazard control in health-based housing interventions and energy efficiency through its improvement of indoor air quality has shown to be one of the most effective ways in reducing the incidence of asthma. So we're looking at, again, a sustainable Medicaid funding model. We're building evidence-based program with community partners. The medical center has completed a pay-for-success feasibility study with GHHI, and we are now recruiting Medicaid managed care plans to bring forward a larger, more sustained program using the alternative payment mechanism. And we're leveraging those community benefit dollars through the hospital community benefit programs at local foundations. So I think we're ready for questions, and thank you for allowing me to participate today.
Great. Thank you, Ruth, for that wonderful presentation. I think we should have time for one, maybe two questions before turning it back over to Kate to wrap things up. So first question, aimed at either Cindy or Ruth, if you want to answer. One of the questions was how racial equity plays a role in the work of the presenters, because it didn't come up in talking about like communities of color being targets for tobacco marketing and use and for poor housing conditions.
Well, I'm very happy to jump in. Racial equity inclusion is one of the core tenets of the work of the Green and Healthy Homes Initiative, not only in our direct service program in Baltimore, but as a standard of our practices and principles across the country. GHHI's work is targeted to the lowest income neighborhoods in the United States, and that unfortunately has a very high disproportionate inclusion of communities of color. Much of the work that we do through the Green and Healthy Homes Initiative to do the intervention work is utilized by hiring and training from impacted communities, young men and women, to provide workforce opportunities, jobs, and careers in environmental health, environmental assessment, and environmental intervention. And in fact, in a study that we did with Cornell University and the Center for Employment Opportunity in our GHHI Buffalo site, we showed that by utilizing these practices and training for health-based housing intervention, we were able to improve the wages of workers who had done work in property maintenance and some rehabilitation work by $4,000 to $8,000 a year. In our own practice in Baltimore, the majority of our housing intervention crew members have come from impacted communities who were previously unemployed, homeless, and now have had long-term careers in this work.
Thank you. Cindy, did you want to add anything to that, or we can move on to?
Well, just to mention or to stress that tobacco control is definitely a health equity issue. And the way that we combated this in the communities that we serve is we brought partners to the table in communities of color, and they helped us advocate for these policies.
Great. Thank you. So another question for you, Cindy, and it's kind of a little bit of a double question, 2 for 1. One being, have there been any case studies written up about Trinity's work on improving community health? And the second being kind of the 30-second version of what the financial model for community health and well-being is, and how if payers aren't reimbursing Trinity Health for tobacco prevention, how this work can be sustainably funded.
Well, actually, because it is so new to Trinity Health, as I mentioned in my presentation, we really only began to focus on this in 2015. We do not have any studies to this date, not saying that we won't in the future. But to answer your question in regards to the financial model, traditionally our community benefit dollars in our local hospitals were towards different programs. What we're doing is we're taking those dollars that we might invest in X, Y, and Z and focusing them on our policy investments, such as Tobacco 21 control measures.
Great, thank you. And then one more question for Ruth, which is again also a kind of 2-for-1, is one where Green Healthy Homes Initiative is active, and whether you do policy work, programmatic work, and both, which I think is just kind of a reiteration of your presentation.
Yeah, that's fine. We work nationally both on federal policy, and we work across the country with governors, mayors, and county executives to put forward standards and practices and policies that instill health-based housing work throughout the country, and to align asthma reduction and lead to hazard reduction in all of their housing policies. We are active as approved GHHI site locations in 30 cities, counties, and states across the country, but we are equally working on federal policy. If anyone wants to know more about that work, they certainly can email me at ranorton@ghhi.org. But we've had a huge impact on getting HUD to adopt these standards around health-based housing in all of their general NOFAs, so I can spend more time on that.
Great, thank you. And once again, thank you to both Cindy and to Ruth Ann Norton for presenting with us here today. And I want to turn things back over to Kate to wrap things up.
Thanks, Derek. And again, thank you so much, Ruth Ann and Cindy and Derek. Your presentations were really terrific. I know I got more out of it every time I hear you guys present. So again, thanks to the presenters. Everybody's contact information is on the slide. If any of you that were participating on the webinar want to follow up with any of us that were speaking, I'd like to again recognize and thank the Kresge Foundation and Nemours Children's Health System for funding today's webinar. And mostly, I'd really like to thank everybody that's been on the line. Your questions and contributions have been tremendous, watching them in the chat. We didn't have time to take all of the questions, but we will be pulling out the kind of the key themes of questions and posting our responses to them to the best of our ability with the information that we send out to you post-webinar. So in the next 2 to 3 days, we'll send out a follow-up email, and that will provide you with the audio of today's webinar, the slide deck, any resources mentioned during the presentation, again, the responses to key questions. If you are interested in joining the Policy Learning Lab that we're going to run following this webinar, we'll send you that link for information and applications. And Derek mentioned it at the top, but we do encourage you to complete the webinar assessment so that we can have your feedback to help us improve further work. So you'll see a link pop up at the very close of this webinar, and it will also be included in that email that comes out. And finally, today was part 1 of a 2-part series. So just 1 week from today at the same time, that's Tuesday, July 25th, we'll be presenting part 2, which will be focused on policy to address food insecurity. A link for information on that was also included in your meeting confirmation email for today's webinar, or you can reach out to either us or to ChangeLabs if you're interested in having issue finding the registration information. So please join us if you're so inclined. And have a great day, everybody. Thanks for being with us. We appreciate it.